The opinions and views expressed on this program do not reflect those of the management or staff of Community Media of Staten Island.
Hello and welcome to RUMC Vital Signs. I'm Alex Lutz. On our show, you'll meet the fantastic people who make Richmond University Medical Center thrive. RUMC is an award-winning, full-service hospital located right here on Staten Island at 355 Bard Avenue. To learn more about the full array of services provided at RUMC, visit rumcsi.org. Young people benefit from OBGYN care for routine checkups, addressing menstrual concerns, discussing sexual health and contraception, and receiving guidance on various health-related topics. But when should a young person go to an OBGYN, and what are the very real health concerns young people can experience that an experienced OBGYN can diagnose and treat? Joining me today is board-certified obstetrician and gynecologist Dr. Rita Shats. Dr. Shats is the first obstetrician gynecologist on Staten Island to achieve American Board of Medical Specialties board certification in pediatric and adolescent gynecology. She's a fellow of the American College of Obstetrics and Gynecology, graduated from Ross University School of Medicine, and is the first female physician at Richmond University Medical Center to perform robotic surgeries. She's also personally delivered over 3,000 newborns during her over 10 years as a physician. Welcome to the show. That's quite a resume.
Thank you. Thank you very much.
Thanks for coming on.
I just wanted to correct you. It's over 20 years.
Over 20 years?
Yes.
Okay.
Yes, over 20 years, yes.
Wow. So what made you go into OBGYN? What was that?
I think the biggest reward in my field is seeing babies born. Mm-hmm. Everybody loves the birth, the childbirth, the happy mother, happy father, and
mm-hmm.
giving them the biggest joy of their lives. Mm-hmm. I think that was my, during my first rotation as an OBGYN student, I think that's what prompted me to go into it. Mm-hmm. Plus, signing of the birth certificate is a lot more fun than signing death certificates.
Are you the first medical professional in your family?
Yes and no.
Okay.
As far as MD, I am. As far as being in medicine, my grandmother was a nurse. Uh-huh. So, yeah.
Oh. So I guess we wanted to talk about young people and OBGYN, so I guess the obvious question is, when is the appropriate time for a young person to see an OBGYN for the first time?
I think I get that question a lot from the moms, the aunts. When should I bring my daughter, my niece? And I love the fact that there are no specific age. Mm-hmm. I have two daughters of my own, and what prompted me to go into adolescent OBGYN medicine is that every week I would have 2 or 3 of my daughter's friends, mm-hmm. and they all had issues with their periods, whether it was too painful, too irregular. And I'm like, wow, so many of you guys are requiring my expertise, and I decided to pursue it as a subspecialty. Mm-hmm. So I love that slide that I might have sent you of 21 reasons mm-hmm. of why to see an OBGYN under 21. Mm-hmm. And number 1 reason is my period normal? Is mm-hmm. my period irregular? Is it normal to have pain during my periods? Mm-hmm. Let's talk about sex. How should I protect myself? Can I get pregnant? Will I be pregnant? Those are some of the reasons mm-hmm. to see an OBGYN or gynecologist before you turn 21. Mm-hmm.
Do you find that a lot of your first-time patients are coming for these reasons, like a heavy menstruation or an irregular menstruation, or are they actually coming with legitimate health concerns?
I think number 1 reason is irregular periods, mm-hmm. painful periods. Mm-hmm. I think if the pediatrician can't handle it, I think we're the next runner-ups when it comes to cases like that. Mm-hmm.
And as with anyone who goes to a doctor or a physician for the first time, there's a sense of nervousness. So to try to take away for anyone that's watching, kind of walk us through what would be a first exam that you would give to an adolescent who comes in to see you for the first time?
I think the first exam is in a one-on-one interview and trying to get to know your patient. Mm-hmm. Obviously asking about their health, asking about even asking their mother, how was their delivery? Were they full term, preterm? Mm-hmm. Asking them about if they have any concerns of their own. Are they in tune with their anatomy? Mm-hmm. Do they know what it's like is it the same area that, they understand? Is it, what's the difference between female reproductive system and a male? Do mm-hmm. they fully understand it? I think that's number one, making them feel comfortable, guiding them through their experiences, understanding period, understanding development, understanding what's normal, what's not about their development. I think that's one of the things, making them comfortable. And I think a pelvic exam is not really warranted.
Okay.
At least initially for me, I feel like I'd rather teach them how to do a breast exam. I'd rather explore their anatomy and make them understand what's normal in their physique. I don't want them to do a locker room comparison. You know, what's normal on me may not be normal on someone else. So I think that's number one, making them feel comfortable.
So a first visit may not even be a physical exam?
Yes, I think first visit should be get to know your doctor. Let's talk about you. Let's talk about your health concerns, issues. Let's talk about your period. Let's talk about your sexuality. Are you gay? Are you straight? Are you bi? I think those are the topics that are so important. Are you fully aware of what sexually transmitted diseases are? And can you prevent them? Are you aware of HPV? Human papillomavirus. Have you been vaccinated? Let's go through the list of your vaccines. I think this is something that I need to do. I think everyone should do to get to know their patient. Once they know you care and they can trust you, I think the next step would be the exam.
Well, you actually hit on the point I was going to say. In your field, developing trust has got to be paramount, considering some of the questions you're going to ask someone.
Yes. You're hoping to become their first GYN, and hopefully, I mean, being 22 years in the business, I get to see my first GYN patients, and now I'm delivering their babies. I want to do their care from beginning till end. I want to care about them while they're just exploring their first steps of sexual development and up until menopause. I want to care for them after. So I think it's a relationship that has to develop for life.
Are you seeing any trends here on Staten Island among young women on the island?
I see a lot of obesity. I
Really?
see a lot of polycystic ovarian syndrome. I see a lot of infertility in younger women who are looking to get pregnant. I see a lot of that, and subsequently a lot of diabetes.
And does obesity play a part in good OBGYN care and health?
Absolutely, because we have to teach them how to eat right, how to exercise, how to be at their best, and hopefully prevent morbid obesity. And you know, everyone is aware that if you're overweight, you may have difficulty getting pregnant. So my job is to make sure that I have them at their best health in their teenage, adolescent years, and subsequently into their adulthood.
And you touched on, how does diabetes play a role?
I think diabetes plays a huge role because polycystic ovarian syndrome is one of the complications of polycystic ovarian syndrome is diabetes. So seeing patients with PCOS, encourage them to lose weight and exercise, hopefully prevent diabetes.
So when you're seeing an adolescent for the first time, I mean, does their parent have to be in the room? How do you?
So yes and no.
Okay.
If they're coming to me to inquire about birth control, not necessarily I need to have a parent in the room, because obviously I don't need the parent's consent for prescribing birth control. But when they're coming to me and they're here to talk about their menstrual irregularities or their weight issue or other health concern, I'd like to know about the mother's history. It will help me because although some of the conditions are not familial, some are.
And do you find that, so you, again, going back to the trust here, is there a series of questions how do you build the trust? Is that just something that develops over time, or you just?
I have a little cheat sheet, and of course I talk about their health routine. What do you do when you wake up in the morning? What is your hygiene like? Because that's important for prevention of certain infections. What is your diet like? What do you do what do you have for breakfast? What do you have for lunch? What do you have for dinner? How do you exercise? What do you do on your spare time? I want to make sure they're physically well and mentally well. And I always would like to know about their health and safety at home.
And when you decide a pelvic exam is necessary, kind of walk us through that.
So I usually ask about their sexual activity. Obviously, I excuse the mother, and I tell them, a parent, I should say, step out of the room. And I talk one-on-one and being very honest and say, I would like to know all your sexual experiences, even if it does not, in their mind means they had sex, or I want to know everything. So once I know that they've been sexually active, I'd like to talk to them about STD screening and specific cultures and examinations. We don't necessarily do pap smears, which is, as you know, screening test for cervical cancer, until they turn 21. But we do exams and cultures and other screenings before they turn 21.
And how has your field changed just in the time you've been an OBGYN?
It's changed a lot. I had to re-educate myself, specifically on the language. Teen language is another language. Luckily, I have a teen daughter, so I have a lot of help and support in that area. And I remember growing up, I never spoke to my mother about periods and sex and my sexual preferences. It was assumed to be a girl has to meet a boy and they have to fall in love and they have a sexual relationship, right? And now I have to talk about a partner or a sexual partner, and sometimes it's multiple, and sometimes it's an orientation, which I had to get comfortable talking about it and accepting it. So therefore, I have to talk to my patients freely. So I had to re-educate myself. So it's definitely changed.
And your decision to go for board certification in adolescent, was that something that you decided to do? Did you see a need for it?
I felt like the amount of patients I was seeing, I owed it to them to be an expert in the field. And I wanted to be an expert in the field for my own kids. My daughters brought their friends every weekend, and my sleepovers somehow turned into a consultation night with popcorn. So it was interesting. I had to do what I had to do to survive. And I said, well, self, you probably need to really be on top of it. And I went ahead and collected my cases, went out for my boards, and luckily did well enough to sit here with you and talk about it.
Wow, so you went back, so now you've quadruple board certified.
Yes, I've done a few things, not to talk about my achievements, but it's an achievements of my family and the support of my husband, my kids, who kept pushing me, you could do more and more and more, and here I am talking about it. I'm proud, yes, but also I'd like to offer Staten Island community everything we have to offer for Richmond University Medical Center. We do have an adolescent clinic at the clinic site at 355 Bard Avenue. We see patients there on Fridays, and I also see my own private patients at 2 Teleport. So I want them to feel comfortable seeing us. I don't want them to choose between a pediatrician and gynecologist. I want us to be colleagues and share patients. And I want them to know that they can pick up the phone and say, hey, do you want to see this patient? Can you help me with this patient? And the answer is always yes. So I think that's the relationship. That's what I wanted to let them know, our pediatricians, that we are available for that type of service.
So do you find that most of your young patients are referrals from pediatricians, or they're calling you directly?
Actually, everything is through the word of mouth here in Staten Island.
Yeah, that's true.
But I am kindly grateful to our pediatrician community who are referring patients back to us.
So you wanted to talk about, and you've mentioned a condition called PCOS. What is that?
So PCOS is a very common condition. Unfortunately, I can't tell you what the true reasoning behind it. But it has 2 components. It's chronic insulin resistance and hyperandrogeneous, which means too much of androgen hormones, which is a male-dominant hormone, resulting in anovulation. So these women, they don't ovulate, these young girls, they don't ovulate. And what happens is their ovaries look like, I call it Swiss cheese. So there's mature follicles, mature eggs that don't drop during their ovulation. So when you look at the ultrasound, they look like little bags, little sacs with fluid, hence the condition and the name polycystic ovarian. But they're not true cysts, they're just mature eggs that never dropped during ovulation.
Okay. And what are the symptoms?
So there are multiple symptoms. Most common symptom is irregular cycles, prolonged cycles, acne, hirsutism or hair places like face and chest, oily skin, oily hair, obesity.
And what is who's the risk factor? Who's at high risk for something like for PCOS?
So the highest risk factor of the patients that I found are women who are girls who are coming in already obese, women who have history of moms, aunts with
So
obesity.
there's a genetic component to
There
that.
is. There is a genetic component, and it's also multifactorial component or environment. We don't know exactly what causes it. We truly can't give you one answer to that. But they have, when they're obese, they already have insulin resistance, so they have a very difficult time processing glucose. As you know, glucose have to be metabolized, and if they have high levels of glucose in the blood, that leads to diabetes. So it's a double-edged sword.
And are you just diagnosing it more frequently?
I believe we pick up on it, and you don't have to meet all the criteria.
Right.
You don't have to have obesity, and you don't have to have oily hair and acne. But you have to have a few components that I mentioned. Most commonly, it will be irregular periods, and it will be hirsutism or acne.
And is the ultrasound? So somebody comes in presenting with some of these potential symptoms. Is it the ultrasound that confirms the diagnosis? Is that how you actually diagnose PCOS?
You don't need to have a diagnosis on ultrasounds. You can clinically go in, understand that if you have irregular periods, you have obesity, you have evidence of high androgens in your body, such as oily skin, acne, and it helps to see those multiple follicles or multiple eggs or multiple sacs or multiple bags, whatever you want to call them, Swiss cheese appearance, but it's not entirely required.
And what is, for clarification, what is considered an irregular menstruation?
So a normal cycle is 28 days.
Okay.
It varies, some people 28, some people 29. So oligomenorrhea, meaning prolonged periods, which means you may have a period every 40 days, you may have a period every 35 days. So anything above that.
And if it's left untreated, what are the long-term dangers of PCOS?
So just to be clear, there's no cure for PCOS. You're just controlling the symptoms.
Okay.
So if it left untreated, for instance, if you don't encourage decrease in testosterone levels, you obviously going to have more elevated levels of testosterone, hence the, acne and the oily skin. I mean, we're talking about young girls who are going to be going to the prom. They got to look their best and they got to feel their best. So we have to treat the condition. So we treat that most commonly with birth control, combined birth control, decreasing the estrogen levels, decreasing the androgen levels, and regulating the cycles.
Is there an age group that you're seeing this more in, like later teenage years, early teenage years?
So once they start menstruating, and the average age of menarche or beginning of menstruation in my practice is around age 10. So once they stop menstruating, they see their pediatrician. And everyone knows that when you start menstruating, you don't necessarily have to have a regular 28-day cycle. But once it's taken a little bit of a time, meaning a year went by and you're still irregular, that's when the suspicion arises, especially when they're starting to gain weight, when they're starting to see more hair on their face and their body, when you see more acne on their skin. That's when they come to my office.
Or 10 years old.
Yes.
It's, most people, I think, and obviously being a male, you think that puberty is around 13, 14, and to hear 10, it's kind of shocking in a way.
I think it has to do with the diet. And I think we all know that the obesity has taken a huge rise in the community. And I think I would attribute it to that.
Does PCOS affect a woman's pregnancy, ability to have kids?
Yes, because they don't ovulate regularly, they have a bit of a challenge conceiving, because, when you trying to get pregnant, it has to be around your ovulation time. And when you don't know when you ovulate, and so it's harder to time that.
Right. So, and does it have long-term to when you get into menopause and things like that? Does it also affect?
So what I wanted to touch upon is that when you have PCOS, you have extra amount of estrogen, and estrogen can actually stimulate the uterine lining, the wall of the uterus, to produce extra thickness or extra layering. And that could actually cause endometrial cancer or uterine cancer. So yes, controlling the PCOS is very important to prevent further sequelae.
And birth control is how you control it, or are there other medications?
You can use other medications. For instance, you can do progesterone-only birth control. You can, if you're looking to, depends. If you're looking to conceive, then you have to work around the ovulation agents that promote ovulation. If you're looking not to conceive, the birth control is, of course, the drug of choice.
I can see people who are watching this episode when it airs, they're going to hear PCOS and they're going to go right to Dr. Google and start to Google. But, we try to, Dr. Google is not the end all. So if someone thinks, oh, my daughter's got all these things, I think it might be just best thing to do is give you a call and say, hey, can I come in? Or do they go to their pediatrician? What do you recommend?
Social media is overwhelming. It's educational. Don't get me wrong. I Google at times. You Google at times. Everyone does. But I think it will alarm some of the people that are best not to be alarmed, because, they're growing up, they're forming an identity, they're trying to look their best, they're trying to feel their best. The worst thing they could do is Google PCOS and find out I'm never going to have a baby. And that's the last thing I want them to say.
Right.
And we all are so blessed with all the reproductive assistance out there that most of my PCOS patients at least have one or two.
So it is a livable condition.
Absolutely,
it's not,
absolutely. And the more we know about it, the more we know how to treat it, the better and more comfortable we feel about seeing patients at any age.
Is there any screenings, like early screenings, early detection?
I think that it's hard because I've mentioned that when initially a young lady starts to menstruate, her periods are irregular. So I'm not going to start chasing somebody who's just starting to, and their hypothalamic system is trying to mature, their hormones are just trying to mature, to try to scare them. You might have PCOS. I want to see what that first year or two will do as far as their regularity of cycles. And then, of course, I would like to see them, if it's still not regular, if they're gaining weight. It is also important to exclude other conditions that may cause that, such as hypothyroidism. Often I get a patient that's irregular period, and part of my workup is a thyroid workup. And guess what? They don't have PCOS. They have an underactive thyroid, and I have to treat that with the help of my colleagues, the endocrinologist, of course.
So it kind of goes full circle back to that first meeting with a patient, learning their family history, speaking to them, gaining their trust, and then if PCOS comes out in that, now you kind of have something, I guess, to work with.
Correct. Especially if they have, it helps to have, if they have other siblings, specifically females. If they come in and they say, my daughter has PCOS, my sister has PCOS, my aunt has PCOS, and it helps us, but doesn't mean they have it.
Well, obviously with your board certifications, you're the expert in this area, so.
I'd like to think that way.
Well, thank you so much for coming on the show.
Of
Really
course,
appreciate
it was my pleasure.
Thank you.
Thank you.
If you would like to schedule an appointment with Dr. Shats, you can call 718-273-5500. Her office is located here on Staten Island at 2 Teleport Drive, Suite 207. Richmond University Medical Center has cared for Staten Island and the New York City metropolitan area for over 120 years. You can help ensure that care continues by making a financial contribution to the hospital. Donations can be made in your name, the name of a loved one, or to honor a special nurse or doctor at Richmond University Medical Center. To donate, visit our website at rumcsi.org and click on the Donate button located at the top of the homepage, or you can call 718-818-2106. That just about does it for this episode of RUMC Vital Signs. Thanks for joining us. I'm Alex Lutz.
Produced through the facilities of Community Media of Staten Island.
Are you prepared to save a life? Opioid overdose is the leading cause of accidental death in the United States. Due to their effect on the respiratory system, opioids may cause breathing to stop. When this happens, brain damage can occur after 4 minutes, and death can occur 4 to 6 minutes later. It takes an average of about 10 minutes for emergency medical services to arrive, which can be the same amount of time as a potential overdose death. So it is crucial that treatment be administered as quickly as possible. Having Narcan nasal spray on hand allows you to respond first and help save a life. Naloxone, the active ingredient in Narcan nasal spray, is the standard of care for treatment of opioid overdose. But only about 1 in 5 opioid overdose victims receive naloxone prior to EMS arrival. Now, everyone has access to the same treatment used by emergency responders. Accidents happen. You have the power to save a life.